Our mics here. Sarah will monitor the chat and will inform you if anybody shows up on site.
Okay.
All right. Have a good meeting.
Thank you.
Yes, ma'am.
Let's see. So okay, why don't we get started? Thank you all for joining. This is the Leukemia Committee meeting for the SWOG Spring meeting that's being held live in Seattle. I do hope and plan that we will have a live face-to-face meeting in the fall in Chicago. Maybe a little bit easier for everyone to get to the central part of the states than the West Coast. And hopefully we will not see a resurgence of COVID or any other, viruses or things that keep us apart. So thank you all for joining. Hopefully this will be the last time we'll have a virtual meeting. I know the interaction face-to-face is really important. Before we get started, I'd like to acknowledge the team, the committee, and its leadership. Without the help of or the leadership of all these people, nothing would get done. So as you know, I've been your chair since October of 2012, coming up on the end of my second term, and I do plan and would like to remain in place for a third and final term. These are 5-year terms. We're going to be talking more about this in a moment, but as many of you know, we lost our dear friend and colleague, Dr Coutrey, in the past year. Anjali Advani has agreed to step in and serve as the vice chair of the team. Has done an amazing job and has helped me along the way and is actually organized our open and closed sessions of this meeting. Gail Sperling is our patient advocate. Jerry Radich leads our translational research efforts. Deb Stevens has agreed to take ownership of a working group in SWOG that to develop clinical trials in chronic lymphocytic leukemia. Anjali Advani does the same in acute lymphoblastic leukemia. And Laura Michaels is the head of the and kind of co-chair of a working group, intergroup working group for older AML. So appreciate all of their leadership. And of course, we couldn't get any of this done without Megan Othis in the stats office, helping us with trial designs and mining our data over time, and of course everyone in the stats office that helps with leukemia studies. The operations office, there's been some changes in our protocol manager, but Sarah Cantu has been involved with her team as well, helping us stay afloat through COVID. And then finally, I'd like to mention Susan O'Brien, who is our executive officer and our liaison with the executive committee. And finally, I consider him a member of our committee, even though he is our CTEP liaison, and that's Rich Little, who has always provided us with invaluable advice in protocol development throughout our committee. So I want to thank you all. I hope I always do this off the top of my head. I don't script it. So I really, really hope I didn't miss anyone. And if I did, I will just then say, of course, everyone who is on this call and participates in this committee, we couldn't get the work done without all of you. And having said that, we value having new people join us and look to integrate new people, especially junior investigators who are interested in becoming active in the NCTN and specifically the SWOG Leukemia Committee. And just today, yet another name, Sharad Karana from Arizona has asked to be involved, and I saw him on the call, and I welcome him and anyone else who wishes to join. So with that, I hope that will be the end of my comments, because I really want to sit back and listen to this session that Anjali has put together. I will try not to step on her toes at all, because she's done a great job with the committee getting together our agenda for today. So Anjali, I'm going to turn it over to you.
Thank you, Harry. And first, I was just going to start, if it was okay, just with a farewell to Tracy and also a tribute to Steve Coutre. So let me just see if I can share my slide here. Can everyone see it?
Yes.
Okay, perfect. And so I know that many others may please join in. I just thought we'd start off because I worry at the end we tend to run short of time. So we wanted to just first really thank Tracy Mayer, who's going to be retiring in June. She's been with SWOG since 1997 and been the data coordinator as well as the supervisor. She really has done a phenomenal job and really has a reputation of having the superstar data team within SWOG. And so we really appreciate everything she's done, and we'll really miss her, and want to congratulate her on everything. And I know many others have worked with her, so if others want to chime in, I'd be happy to open the floor here. But thank you so much, Tracy, for everything.
Yes, so pretty much every time we publish our data, the reason why, and every single time we publish it, we get these comments about like how great our data are. Anyway, it's all because of Tracy. So, and like the kind of ongoing, any question we have, this isn't kind of like, when I have a question, I can just go change the data myself. Like that's not how SWOG works. We have like all these checks and balances in place to make sure that we can't do anything to the data. And that's where our data coordinators are so key in making sure that everything makes sense. And the leukemia in SWOG has this reputation of being really like tricky and hard. And people are like, oh no, I can't handle leukemia data. It's too tricky. But they make it look easy, and Tracy's just been such a wonderful advocate for this committee to like not only put her wonderful brain and effort and thought onto this, but also making sure to be an advocate that the committee deserves really great special data coordinators to work with her on this committee and support our trials. So anyway, I don't know what we're going to do when she leaves. We'll make do because she'll be off having a wonderful retirement that she has really earned. But it has been such a pleasure to work with her. And I'm just so grateful every single time I go to analyze data, like on 0106 or S1203. And if I have any question, if somebody's like, what happened with that patient with this? And everything is so clear and well annotated, and we can all better understand the results of our trials because of that effort. So thank you so much, Tracy.
Yes, thank you, Tracy. Before I let you say a word, I'm already breaking my promise, aren't I, of being quiet, but I can't for this. Tracy and I started around the same time. I started in 1996 when I was recruited to University of Michigan by Larry Baker, our prior SWOG group chair. And at that time, both Tracy and I were wearing our natural color hair. Mine dark, hers a brilliant red. And we've both grown up in SWOG, but I could not have grown up in SWOG without her help. She helped me as a principal investigator through S0432, understanding, my first time looking at SWOG data, helping me through that. And she's been a support to the entire committee all along the way. Tracy, thank you for everything you've done for this committee, and we wish you the best in your retirement. I will just say one last thing. I hope this doesn't mean, since we both started at the same time, that I also have to leave now. I wouldn't know what to do, but I'm sure you'll know what to do with your retirement.
Working on that, definitely working on my plans. But yeah, actually, SO432 was one of the first leukemia studies that I worked on. So we did get through that together, and you helped me learn leukemia. It was mutual. Anyway, thank you very much. It's been a great committee. I started with leukemia in 2004, and it's been a great committee, and I've learned a lot. And we've come a long way in that time. So kudos to all of you.
And then next, oops, see if my slide will advance here. And then next, I just wanted to pay a tribute to Steve Coutre. Steve, as Harry mentioned, passed away this past year, and really, I think, was not only a phenomenal clinician, researcher, but really a phenomenal person, and really did a lot just in so many ways. And so I think we just wanted to pay our respects to him. And I know many people have known him probably for much longer than I did. But I just was always so impressed. He was just an amazing person, and really will be greatly missed.
I would like to, say a word. I met Steve in 1981. I went to Stanford Medical School, so I can learn a little bit about human biology and human disease and go back to the lab where I had come from. And Steve and I were first-year medical students at that time. And it was a great pleasure working with him. And unfortunately for me, I did not get to hit the wards with him, where I think, many of us have bonded with, our co-medical students. He went on to the wards. I went on to Larry Kedis's lab, and we lost touch for quite a while. He ended up in my hometown of New Haven for his next level of training. But fortunately, we came back together through SWOG. He was an incredible advocate for SWOG. More importantly, he was an incredible advocate for patients, especially patients with chronic lymphocytic leukemia. He led the charge, and he was passionate about that work. And I use the word passionate because many of you have heard my passion at times, and I found a kindred soul in Steve with his passion. And so he agreed to be the vice chair of the committee, and really took the reins in acute lymphoblastic leukemia and chronic lymphocytic leukemia, as well as whatever we did in acute promyelocytic leukemia. I remember when he decided, he let us all know that he was going to take a 6-month sabbatical, and he asked me if he could stay on as the vice chair, and I said, absolutely. And although I do get advice from my wife sometimes on some of these issues, so I asked her, I said, what do you think? Should I let him stay on as vice chair, even though he's going to be doing a sabbatical in Italy? And she completely missed the point of my question and asked why I wasn't taking a sabbatical in Italy. But I think with Steve passing at such a young age, I think in retrospect, he was a very private person, but he was probably dealing with something even back then and knew what was important in life. And so he and his wife took that time and spent it in Italy. And I think that's an important lesson for all of us not to forget. Our time on this earth is not unlimited, as we hear every day from our patients and unfortunately also from our friend and colleagues. So Steve, I miss you. I'll stop there.
Would anyone else like to say a few words?
Well, I had a great pleasure of working with Dr. Coutrey on some of his studies. At one point, there was a lot of turnover at Stanford, and his data entry people were all gone, and he got online and filled out forms for his patients himself. It was truly amazing. I've never worked with anyone quite as humble and as really, truly genius and generous as he was. He's a great guy.
I also loved the way that he was like was so good at direct speaking and cutting through the BS. And sometimes people will kind of talk around things and he would just cut through it and let us like actually get to the real issue and talk openly about it. And I think he will be sorely missed because I think we resolve many potential issues and conflicts much more quickly for having somebody who is willing to do it. And sometimes I feel like that's a really challenging position to do, but everybody knew he was so nice and so it was never personal anyway. On my end, sitting not as a clinician, but sitting and watching people try and navigate these complicated situations, he just always made it better and easier, and he will be and calling people on getting them to say what the real issue is and just get directly to it. He'll be really missed.
I only knew him from sort of intermittent contacts, but two things that I'll remember the most about him is first that I've worked very closely with people he's trained, and those people are remarkably attentive to patients' needs. They are remarkably insightful about the limitations of medicine and the what we need to, and the humbleness of this job. And yet they are also committed and passionate to the mission. And I think the people he trained, and I'm thinking about three in particular that I've worked closely with, those people reflect his values. So that's really good. And then I'll never forget, as many of you know, I was the PI of, or the co-chair of 1612, which had a rocky road. And there was one day that was really, really awful. And he called, he said, "What the hell's going on?" And he walked me through that day. He normalized some of what I was feeling in terms of responsibility. He helped me navigate that in an incredibly warm, thoughtful way. And it really meant a lot for me to be able to understand what I was managing. So I will never forget that phone call, and I will never forget the footprint he's left on our colleagues.
Eli Jabour, I'm new to SWOG, and I learned about Steve Coutre long before I read his paper as a fellow, as a resident. And then I dealt with him directly through the randomized trial of inotuzumab and the stormy start. What I found in Steve, a strong, as Harry mentioned, a strong advocate for SWOG. And as Megan mentioned, he's humble, kind, and he's so thoughtful in resolving conflict. So we're able to work with the Alliance, and He defended SWOG and were able to co-lead the studies, and he stood for what's right. And for that, I will miss him dearly, as all of you.
Well, thank you, everyone. That was really wonderful. So I think now we'll go ahead and start the rest of the program. So I'm going to start with Debbie Stevens is going to talk a little bit about her open study in CLL. So they're perfect.
Perfect. Let me get this organized here. All right. Thanks for letting me present this study today. And I think it's very fitting to present it right after talking about Steve Coutre. As of course you all know, he's been really integral to many advances in the field of CLL. Also, I've spoken with him on various patient-directed education, and I was always struck by how incredibly sensitive and how great he was at helping the patients to understand their disease. And I think that that made a great impact on many individuals over the years. I'd like to spend most of my time today talking about the current SWOG S19 study, but I did have just one slide as kind of an overview of the current cooperative group CLL studies. And of course, I'm going to spend most of the time talking about our SWOG study, and this essentially is to compare the different studies and the different populations that they're studying. So the SWOG study is frontline. It's for all ages of patients. It's specifically for high-risk patients who do not yet meet standard criteria for therapy, those who are on watch and wait, and the accrual is ongoing. The current ECOG study is a frontline study. It's for patients less than 70 years of age. It is for lower risk patients, so patients with deletion 17p are excluded. It is for patients who require therapy for CLL by standard criteria, and the accrual completed, I would say, in record time for this study. And so the analysis and patient follow-up is ongoing. The Alliance study is also a frontline study. It's now for patients over the age of 65. It is for all risk levels, so deletion 17p patients are included in this study. Again, it's for patients who require therapy for CLL by standard criteria, and the accrual is ongoing. However, I just looked at the numbers this week, and it looks like they probably only have about 40 to 50 slots left on their study. And so if you have an older patient that is getting ready to start therapy for CLL, just keep in mind that this study is almost fully accrued. Probably by the end of the year will be so. So as I mentioned, I'd love to spend most of the time talking about the SWOG CLL study, the S1925 study. As a reminder for you all, this is a randomized phase 3 study of early intervention with venetoclax and obinutuzumab versus delayed therapy with venetoclax and obinutuzumab in newly diagnosed asymptomatic high-risk patients with CLL, otherwise known as the EVOLVE CLL study. This study has been done with a large collaboration of folks who are interested in CLL. As you can see here, in our ECOG and Alliance study champions are noted. As you know, asymptomatic CLL patients in CLL still get the current recommendation of watch and wait or watch and worry, whichever fits their personality. And this is largely because any prior early intervention studies with standard chemoimmunotherapy agents such as chlorambucil, fludarabine, cyclophosphamide did not show any survival benefit. We recently saw the first results of the German CLL-12 study, which actually studied ibrutinib in this setting. And as to date, it has not showed any benefit in overall survival, and so still has not reached a standard of care. even though we have lots of great ways to stratify patients by risk, we still, you know, a patient who's newly diagnosed patient with high risk disease, we still recommend watch and wait. One of the best predictive markers right now is a compilation of the CLL International Prognostic Index, which is both molecular and clinical risk factors. I've listed these factors to the side, and these are important as they form the enrollment criteria for the S1925 study. So you can see deletion 17p or TP53 mutation is a very high risk factor and gets 4 points. An elevation of serum beta-2 microglobulin or unmutated IGVH status gets 2 points each. If they have a rise stage anything other than 0, they get 1 point, and an age greater than 65 patients get 1 point. Patients who have a 4 or higher risk factors are considered high, 7 or higher are considered very high. And you can see by the numbers here, the 5-year overall survival rates for these patients in the high risk are only 53%, and the very high risk are only 20%. And in this group, at 5 years, less than 50% of these patients are treatment free. So they are a group that needs early treatment, and their survival is shorter than their peers. And so, of course, this is a group of interest for early intervention. As you all also know, frontline CLL therapy has changed from chemoimmunotherapy to targeted therapies. And a very popular regimen right now is the combination of venetoclax and obinutuzumab, because this has been shown to induce deep MRD undetectable remissions for patients. In the frontline CLL14 study, this regimen was given as a limited course of 6 months of obinutuzumab therapy and 1 year of venetoclax therapy. At 3 months following therapy, or month 15 of the treatment, 76% of patients were able to achieve MRD undetectable remissions. So one thing that's very attractive about this regimen, it's effective, it's tolerable, and it's time limited, and so seems to be a very optimal regimen for early intervention. And the main question of our study is, can early intervention with venetoclax and obinutuzumab prolong survival in high-risk CLL patients? Really, I think is a very important question and trying to change the natural course of this disease. The inclusion criteria for the study include patients who are diagnosed with CLL or SLL within 12 months, and they must not require therapy by the standard IWCLL guidelines, so they must be asymptomatic and have no cytopenias. They cannot have any prior CLL-directed therapy. Their CLL IPI score must be 4 or higher, or they could also gain entry by having complex cytogenetics, and we have defined this as 3 or more cytogenetic abnormalities. Patients must have a good ECOG status of 0 to 2 and no GI malabsorption, as venetoclax is an oral therapy. I've included the schema here. Again, as I mentioned, this enrolls newly diagnosed patients who are asymptomatic, high risk. They will be stratified between high risk and very high risk. They are randomized 2 to 1 to early versus delayed therapy with venetoclax and obinutuzumab, which is given as per the CLL14 study with 6 months of obinutuzumab and 12 months of oral venetoclax therapy. I made a special note at the bottom. This is a great advantage to the patients also, even from a CLL standpoint, also from a financial standpoint, as venetoclax and obinutuzumab are completely provided by this study, and that is whether the patients are on the early or delayed arm. We have a lofty goal of improving overall survival in this patient population, because I think it's the most important question to ask for these patients, and have a planned total accrual of 247 patients. Secondary endpoints are listed here, including safety, overall response rate, duration of response, progression-free survival, time to next treatment, quality of life, and major translational endpoints are MRD, ability to achieve MRD, and resistance. So the current status of this study did open in December of 2020. which of course was right during the height of the COVID pandemic. And so our current accrual is 18 of 247. And it's a little bit slower than we would like. And so I'd really love to encourage all of you who are on this call to make sure that this study is open at your institution, just because these patients are relatively rare. Of course, there's a limited time point of 12 months after diagnosis, and so have to get these patients on fairly quickly after diagnosis. Just wanted to call out some SWOG centers, University of Rochester, also Cleveland Clinic, that are accruing patients to this study. Kind of a current update, we have just submitted an amendment and we're working on an additional amendment. There was an error in where the MRD samples should be sent. And so this is corrected in the current version, but I've included it here just to ensure that your coordinators know where to send this, and that ARUP appreciates a heads up via email so that they know to expect this sample. There's also a clarification of bone marrow biopsies. These are required at pre-treatment, 15 months post-treatment, and relapse. They are not required at enrollment. During those procedures, pathology and flow should be sent, and at 15 months, an additional sample of aspirate would be sent for MRD testing. And it is optional, but we highly encourage aspirate for tissue banking at each of these bone marrow biopsies. I have my email address listed here, but I'm happy to complete my presentation and see if anyone has any questions. But again, I think, you know, this is such an important question to ask, and I would really encourage you all to be involved in this study.
Debbie, that was great. That's a great presentation. One question for you. Can you remind me what the survival benefit you're looking for between the two arms is?
Yeah, so we've estimated that the delayed arm would have a 6-year rate of overall survival of 60%, and we're aiming for 80% in the early intervention group.
Perfect.
Debbie, this is Harry. So I'd like to first give a quick shout out to Helen Ma, who's at the VA in Long Beach, where she opened the study. So it's great getting cooperative group studies, NCTN studies open in the VA system, and appreciate that. But you probably were just looking at her question then about how do you sell this to patients who may be feeling well?
Yeah, that's a good question. And I think that the best way to do this is you start at the beginning. So right when you see the patient for consultation, especially helpful if this is the first time that they've seen an oncologist, you know, you say, hey, I'm going to check some risk factors, and they might tell you that you're high risk disease. But don't worry, if you are high risk, we do have a potential opportunity for a clinical trial, especially for your risk group of patients. Now, when somebody has already seen another oncologist and they've already on the watch and wait pathway, a lot of them are, and I think that's fine, that they've kind of settled into that mindset and have decided that's a good option for them. But I think, you know, really, especially those patients who are really high risk, you know, pointing out that, you know, their overall survival is lower than the average patient with CLL. And, you know, this is a study that we're doing in order to try to attempt to change that. And so I do think, you know, we're getting to the point where, you know, there are things that need to change in the CLL world. And one of them is, you know, how do we cure CLL? Not that I think that this is going to be a cure, but, you know, if we could give patients a remission long enough that they never need another treatment, you know, I think this is trying to change the natural course of the disease. And so, you know, I really spend a lot of time talking with my patients about it, and especially folks who seek out, you know, consultation at a, you know, a tertiary center. A lot of them are really interested, and they know, you know, they've read about, they know what having deletion 17p means, or having a TP53 mutation means, and they're really motivated to try to, you know, do something to change the course of their disease.
Definitely. It's just when I'm super excited, and many people are super excited about it, but then when they're like a hole in my organs or infection in my brain, I'm not really sure. like how to, like I say, it's very, very rare and like we're going to be monitoring it very closely, but there's like, I need to think about it. So I actually have another appointment with him in a few days, at least the more recent one. And so just.
So I have a question along those. I have a question along those lines. One of the advantages of diagnosing AML early is before patients have really bad cytopenias. So, is there any data that intervening earlier with a venetoclax-based regimen might actually be better tolerated, since most of these patients are going to end up needing treatment anyways?
Yeah, and that's the point I was going to bring up, that sometimes when I talk to the patients about it, because most of these patients have a fairly low, white blood cell count, their lymph nodes aren't, bigger than 5 centimeters. And so those are all risk factors for tumor lysis syndrome with venetoclax-based therapy. And so I find that people who are getting treatment with a lower disease burden have a lot less risk of, tumor lysis. The patients we've started on study, none of them have required hospitalization for tumor lysis management. And I think that they're generally at a much better place in their disease, so they're strong going into the study. And so I don't know the answer to that yet, Harry, but I hope that we'll answer it with this study, because from what I've seen, it has lowered the side effects that patients experience from the therapy by doing it early when the disease burden is less.
And it's kind of a cultural thing, right? I mean, if CLL is the new CML, in CML, most patients aren't sick when they get diagnosed at all, but the clock's ticking, right? It's whether they're sick or not, that the clock to progression is ticking. And, now with, tyrosine kinase therapies and CML, you can put them on a normal life expectancy as opposed to a median survival of 6 or 7 years, right? So it's this same kind of dilemma. You taking care of people who are well, and anything you do to them are going to make them sicker. But that's the only path to curing them.
Jerry, that's a really interesting point, because the reason why we want to intervene early is to prevent that progression / crisis. So, Deb, for you then, is there any data that might suggest that early intervention will decrease the risk of progression to a Richter's transformation, or maybe it's the opposite?
That's what I hope to gain by doing this study. I mean, there's no data supporting that in standard chemoimmunotherapy, but I, think that there could be a potential that we could show this here. And I think, Helen, I would also say that, these people, they're worried about the side effects of treatment. I don't think I've ever had these people in the high risk group not require a treatment at some point. Yeah. And so, it's either side effects now or side effects later for those particular patients, because, all of these people, within probably 3 years, most of these people are needing some sort of treatment anyway. And this is a great way to get it for them for free.
All right, I will relay all this in a few days, and hopefully we'll have enrollment.
Let me know how it goes.
And thanks for being active in the VA system. Really appreciate that.
Yes, I very much appreciate that. I think I saw a question too about some other barriers that sites are having. And I think there's a common theme across the country now with COVID of clinical trial staffing shortages. And so I think there are a lot of centers that just, this trial maybe didn't make it to their top priority list, and so they're not allowed to open it yet. I mean, major centers, like I know, despite having, Dr. Erba as our chair and the ECOG champion or the Alliance champion being at Duke as well, Duke hasn't been able to open this study. And so there are, major centers that are just, like we all are, we're all struggling across the, across the country of getting enough staffing to get these trials up and going. And so, anything I could do to add priority to this study, I would love to do. So I think that's one issue. It's been kind of a slow opening process through COVID across the country. And then, COVID has been huge, but I'm hoping that the, introduction of Evusheld for patients will help people feel a little bit more comfortable, people were scared to put patients on early treatment because they didn't want them to, not respond to COVID vaccine or, have complications from COVID. But like I said, I'm hoping that Evusheld will help people feel a little bit more comfortable there. And then I think the other risk factor is there are quite a few centers that don't have access to all of the testing that's required to get patients on the study. So, most places can get FISH studies done, but, getting testing for TP53 mutations is not uniform across the country. I feel like most people don't check for beta-2 microglobulin. And so, just trying to get that education out there. I think it's very difficult for some sites to test for IGHV testing. And so I do have a meeting with CTEP where I'm going to talk about accrual barriers and, kind of try to see if there's any way that we can get, centers that don't have access to these studies. Is there any way for us to fund them sending those labs centrally to see if we can get the answers? And so we know if those patients are even candidates for the study. And I think other comments, Laura Michaelis says one thing to weigh in is the risks of immunosuppression from obinutuzumab. Yeah, I agree. Both are very immunosuppressive, CLL and obinutuzumab. And the nice thing about this regimen is once patients get off of the regimen after they're done with their year, we do see really nice recovery of the immune system. So, in theory, they should be at lower risk of infection once they're done with the active part of treatment.
Bruce, did you have a question?
Gail,
I just wanted to say that I passed on some information to Helen how to contact me. I'm the SWOG community rep for veterans. I was diagnosed with CLL at Long Beach VA. Okay, the person who treated me is Dr. Thomas Kipps. And Dr. Susan O'Brien is an advisor to an organization I belong to, which is the CLL Society. And I'm a senior member there, and we handle questions like this and educate the patients along the way. Be happy to do it. It's no charge. I've been through Gazyva only. I fortunately have not had to go into venetoclax, although that was a next step if I did not have a good second round of treatment with Gazyva 7 years after the first. And so we can help these patients overcome their fear of the side effects and share with them their journey. And it's all peer-to-peer, no charge. And so Helen and I have exchanged emails, and I'll be very happy to contribute in any way I can. Having the disease, I know all about it. Thank you.
That's very much appreciated. Thank you.
I didn't even know, Bruce, I didn't know that was even possible. Which is embarrassing for me as the chair of this committee. So something maybe offline I need to talk to Gail in more detail about how to formalize that kind of referral, asking a patient if they'd be interested in talking with another patient with the disease, because they're always asking that. Chat rooms, and it'd be better not to be in a chat room. Better be talking to someone like you, Bruce.
Yes, sir. And I also do that for Leukemia and Lymphoma Society already as an advisor, because when someone's getting ready to be treated, they want those of us who have been treated to talk to them. I do that as an advisor periodically as well. It's a wonderful avenue. Please work with Gail. You can also contact me directly. We don't have to worry about any protocol except Bruce and Harry to get the job done.
Can I just say that, working with Bruce has really been a delight. We're both here in Southern California. And, I just want to emphasize the role of the community advocate is to really bring in that representation of community organizations, community representation, and the services that might be available out there to help. So it might even be helpful to Bruce if you can be on the accrual call that is coming up with Deb Stevens. So thank you for speaking up. Great.
Yeah, Deb, I will help you in any way you need. Okay, that's an open-ended offer, not just for today. It's for in perpetuity during the course of this disease.
I appreciate that very much.
I will send you my email via the chat so that we can connect.
Perfect. I appreciate that a lot.
Before we move on, I want to give a shout out to Dana and the protocol project managers for working on the consent and the plain language version of this study that will be coming out.
Great. So thank you, Debbie and Bruce and everyone. So we're going to, I think, next go to Tara and Paul are going to talk about their MyeloMatch study. And
Hey.
Paul, I know Tara's on service, so I couldn't remember which of you were going to present today.
I'm gonna share my screen and then load the slides. Can you see the slides?
Yes.
Okay. Well, thank you, Anjali. Thank you, Harry. Just want to pull my hat again to Steve, humble gentleman scholar, a clear example to emulate. So on behalf of my colleagues, Tara Lynn, Anna Mosley, Megan Othis, I'm gonna present this this project, which is hopefully gonna open soon. As Anjali mentioned, Tara is on service and is dealing with an acute leukemia epidemic in Kansas. So that's why I'm speaking on behalf of the team. So this is a study that's part of the MyeloMatch program, which is a randomized phase 2 study of novel therapies in younger patients with high-risk AML. The objectives, the primary objective of this study is to compare the rate of measurable residual disease negative remissions between each of the experimental regimens and what is still sort of considered the standard, the famous 7+3 regimen. The secondary objectives are to essentially look at the toxicities of each regimen and then the usual survival endpoint, the complete remission rates, and then to try to find some correlations between the rates of MRD negative remissions and different genomic subgroups. And then there's a banking objective to bank specimens for future studies. Inclusion criteria, so this is in the young basket of the MyeloMatch program. So patients who are 18 to 59, newly diagnosed with AML. These patients should have adverse risk per ELN criteria. And then also patients who have an antecedent hematologic disorder or therapy-related AML are eligible. Patients with the FLT3 mutation or the 922 translocation are excluded from this protocol specifically because certainly for the FLT3 there would be a separate protocol. They have to have an adequate performance status. And then because this regimen is anthracycline heavy in a way, patients should have adequate cardiac function, and if they had been treated with an anthracycline, a cumulative lifetime limit of prior anthracycline treatment of 200 per meter squared of daunorubicin or equivalent. Prior malignancies are allowed as long as the natural history of such malignancy does not interfere with the regimens. No concurrent therapy for such malignancy is allowed except for hormonal therapy. One of the regimens for this study is the CPX liposomal daunorubicin cytarabine agent. The reason we're excluding patients with Wilson's disease or other copper metabolism disorders is that the formulation for CPX351, the liposomes, is very rich in copper. And then the usual criteria for patients with HIV infection, hepatitis infection, obviously women with childbearing age and men would have to use 2 methods of contraception. Importantly, the patients must have agreed to have their specimens submitted to translational medicine under the MyeloMatch program. And then patients must be offered the opportunity to participate in specimen banking. So this is a general schema. So patients get enrolled, they go into MyeloMatch registration, they get screened as part of the master screening and reassessment protocol. Based on that screen, if they fall into the high-risk category, according to the criteria I mentioned, then they would go on this trial, and then they get randomized to one of 4 arms. The control arm is the standard 7+3 with cytarabine daunorubicin. Arm 2 is 7+3 plus venetoclax. Arm 3 is azacitidine and venetoclax, and then arm 4 is the CPX351, the liposomal daunorubicin and cytarabine. And this is a little bit more detail on the schema. You can see the doses of the different regimens. We're using the 7+3 plus venetoclax regimen as developed by Rich Stone and colleagues. The AZA-VEN, the 7+3, and the CPX351 are all standard. At the end of their induction, patients will have MRD assessment. I should mention that the MRD assessment will occur at the end of induction for arms 1, 2, and 4. For arms 3, patients will have their MRD assessment after 2 cycles of azacitidine and venetoclax. Statistics, again, it's a 1-to-1-to-1-to-1 randomization to each arm, stratification based on age and also P53 mutation status. We're hoping to have up to 268 patients screened, taking into account screen fails. The null hypothesis is based on data we have from SWOG 0106, where the rate of MRD negative CR in high-risk patients was around 35%. The alternative hypothesis would be an absolute improvement in that rate of 55%. There will be an interim futility analysis based on the first 30 patients randomized to each arm. Survival endpoints will be estimated based on Kaplan-Meier, and then the final analysis would be 3 one-sided tests comparing each regimen to the 7+3, with the outcome being MRD negative remission, and then toxicity will be analyzed to within 13%. Current status, as you recall from last year, the concept has been approved at triage. It has been reviewed by the Leukemia Steering Committee, and we've had some dialogue with the committee back and forth and modified the program accordingly. We have an advanced version of the protocol that is written, has been through different iterations with, again, feedback from CTEP. And we are in the process of finalizing the protocol, and hopefully this will be ready for prime time by the end of the year. And I think I'm going to stop here and answer any questions if there are.
All this is Anjali. Can you remind me how it's going to work in terms of the risk assignment? So the samples are going to be sent centrally, right, to Jerry's lab? Is that right?
Yeah. Well, yeah.
And what is the time frame for getting the results back? Can you remind me?
I think it's going to be
Within
around
3 days.
Yeah.
Okay,
Thank you, Jerry.
thank you.
Yeah, Laura has a question.
Thanks, Paul, and thanks for all the work that you and Tara have done on this. I have a question, and that's probably not that relevant to the copper issue, but in 1612, we had different eligibility criteria for the different arms. So if somebody didn't meet the criteria for arm B, they could be randomized between A and C, for example. Would a similar sort of approach be possible here, just in case there's somebody who wouldn't be eligible for one or the other arms, we wouldn't have to lose them?
That's a good thought, good idea. We haven't built it into the protocol that way, but you know, it's not a bad idea. I don't know as far as stats are concerned and all that, how things would have to be adjusted, but it would be nice to see how you did it with your trial and maybe try to mimic it.
I mean, we've done it once. We can just do the same stuff. It's just a matter of you defining those different criteria. And then also the concern is we have to inflate the number of patients on the control arm is what that ends up doing. And so there will be like some scientific review at CTEP about the proportion of patients that the inflation and like the total study sample size to account for that. In Laura's study, we thought that the rates were going to be pretty low because it was like autoimmune disease for Nevo. And anyway, and the rates were low. There were just a handful of patients on both. So we can do it. It's not like it's more, the issue isn't the technical side. It's more kind of getting the buy-in to inflate the sample size to allow us to do it. And in 1612, we were allowed to do it also because the goal was to have as minimal of eligibility criteria, which I think is like good practice in general. Anyway, it's free. It's not free. And the costs have to be approved by CTEP, I guess is the thing, but we can do it. And we can also change that. We can change that in the future if that is a change that wants to be made. We don't have to solve it all.
I certainly would not want to derail anything on the basis of copper, right? Like all I was just thinking is if these are all being compared to a control arm, you could have alternative entry criteria for the different arms.
I love that feature of your trial, Laura, and I love that you did such a nice job advocating it and opening the door now for us to think more about that when we do these multi-arm studies, because if they were independent studies, they probably would have slightly different in eligibility criteria. And it will be a bummer to say patients aren't eligible because one arm isn't a good fit, even though there are other arms.
Yeah, I hadn't thought about it. I think it's a good idea. One question is, I don't know if there's a way to estimate if we did not follow that design, we just stay with the way we are, how many patients would we lose? I mean, Wilson's disease, copper metabolism is not very common. So this is more of a safety, safety criterion to just avoid the one patient who may be having
absolutely
Wilson.
100%. So it's not about the copper, and again, no reason to upset the apple cart for that. But if there's anything else, and the other person I think would need to weigh in on this is Boris, because I've heard Boris be extremely strict. He's the CTEP statistician, extremely strict that you're always comparing apples to apples when you're doing a trial like this. So
yeah. The one thing I could think about that may potentially be more common would be someone with an anthracycline prior exposure, like a patient with breast cancer, lymphoma, etc., where we're above that 200 limit. But if we include those patients and we follow that design, they will automatically be assigned to AZA/VEN. There would be no randomization. So yeah.
Right,
And
I
the,
think
the
it,
trouble and the trouble with that is the sponsor of the AZA/VEN arm would say, "Let me get this right. You want to put all these patients with prior chemotherapy
Therapy-related, yeah.
and all this toxicity from prior chemotherapy on our arm? I don't think so."
well,
Yeah.
so, yeah, exactly. And we didn't have that. What we had is you had to be eligible for the control arm and one of the investigational arms. So there was still going to be always a randomization. And so somebody still has to be able to fit 7+3. They still have to be fit. They still have to have the core eligibility criteria. But anyway, just something to think about.
Yeah, Laura, not to continue, but do you remember what proportion of your eligible patients ended up following that path? Or, I mean,
3 or 4%. It was a small percent, which is about the range that you would really want it to be, because like Laura said, they have to be eligible for the control arm. Half of them are going to be randomized to the control arm. And so the control arm sample size is increased a little, but if it's a small number of patients and it's kind of more philosophically the right thing to do is to make this trial available for those patients, then like in 1612, that was a reasonable sell, but they have to be eligible for the control arm. Yeah.
So Laura, you said it's not about the CPX 351 arm, but actually maybe it is. I mean, the Wilson's disease might be the best example of allowing that kind of registration.
I mean, one of the other things to think about is excluding people in even a small percentage of people has a leveraged downstream effect for MyeloMatch, because they have to be able to enter MyeloMatch at diagnosis and stay on the tiers. So if you exclude somebody from your trial because they have Wilson's disease, that means they can't go on to get the ARRAY study. That means they can't go on to participate in the transplant studies. So we're looking at a bit of a waterfall, or a bit of a widening cone. So being whatever tricks we can come up with to be as generous as possible to keep people on the early studies has a lot of downstream accrual effects.
Rich Maysgars has an important question. In that, we thought about this a long time, the control arm for high-risk patients, what should it be? There was a very strong feeling in the Senior Science Council and on the Younger AML Working Group that we really haven't proven that anything is better than 7 and 3, although we might have our favorites. You'll remember, we're still trying to get this published, but 1203 looked at IDA and high-dose Ara-C, not IDA flag, but high-dose Ara-C with or without vorinostat, and there was no difference in survival with that regimen across the board or in any subset of patients. So the only data I know of using a more intensive regimen is from an EORTC study where in a subset analysis of patients with, that less than 45 years old with high-risk disease, there may have been a benefit of an intensive regimen with high-dose Ara-C. So we thought a long time about that and decided that it should still just be 7 and 3. Yeah. But your point's well taken, Rich.
I wonder if he's asking more, though, would you treat those patients with Ven-Aza or want to give them Ven rather than 7 and 3 or CPX?
Well, that's again the question. If people think that horse is out of the barn.
And the one point that we made, as we were discussing this issue, is, obviously CPX is approved across all age groups for, MDS related, etc. But if the randomized trial that put CPX on the map did not include young patients, so that was one of the arguments that, even though, we say, okay, you're 45 with a secondary leukemia, we're going to do CPX, but we really don't have randomized data showing that CPX is better.
And I believe we now know that Jazz will be supplying CPX 351 for the study.
I think will also be one of the things everybody can be reassured about is I think accrual and screen failures will be very, very closely watched. So if we are seeing people vote with their feet and take certain populations out once they pass through that screening, you can bet that's going to raise some flags about our designs and mean for some adaptations. Because I think everybody at CTEP is very well aware that people may have implicit bias. I'm not saying that that bias is wrong, but I'm saying that that bias has not been proven.
If this is, actually, Jerry, you're on. Would you like to just say a few more words about the master screening and reassessment protocol and how samples will be divided up when they come in?
Sure. So how this is going to work is studies will be sent for mutation analysis to find if there are some actionable mutations that will put them on the trial. Cytogenetics and flow cytometry. So the grant has moved from the Hutch to children. So one sample will be going to him, one sample will be coming to Min Fang here at the Hutch to do cytogenetics, and she assures us she can get that done within 3 days, as long as Leidos pays for enough staffing. And then the mutation status will be going to the MOCA lab at Fredericks, the NCI facility, Monday to Thursday, and then from Thursday through the weekend, we'll be doing it because we're open on the weekends and they aren't. So your genetic stuff will be done no matter when you send it in, although I try not to encourage people to be seeing people on Fridays. That always happens where most of them show up. And so then the mutation analysis, everything else will be directly piped into this so-called MDNet, which is a algorithm box that David Patton's putting together, where patients will be assigned to both protocols and arms based on their mutation to cytogenetic analysis. Again, that's got to be done within 3 days, which will be interesting. Is that what you wanted to hear, Harry? Oh, you're okay. You're on mute, but that's okay.
Yeah, thank you.
Yeah. And
back to you, Anjali.
And Cecilia will come up soon and talk about all the other fun stuff that we can do.
Cecilia, you want to go next?
Yes, doing a sound check. Can everybody hear me?
Yep.
All right, I'm going to share my screen. And everyone can see my slides?
Yep.
All right, well, thank you very much for giving me time to speak today. I'm a pathologist by trade, hematopathologist and a molecular pathologist. And I also serve as Jerry's medical director for his CLIA laboratory for the Leukemia Committee, where we do a lot of your trials. So the overview for this presentation, I will go through the correlatives for MyeloMatch, specifically the Genexus assay. And the MRD testing is the next segment of a couple of things that we're talking about. And then I want to go through a new technology, high-C sequencing, and maybe discuss how we can potentially implement that into some of our studies. And then finally, touch upon the S1905 work and what we've been doing there. So this is the current clinical trials that we have going on in molecular oncology. As you can see, we have a number of active trials. These cover the gamut from T-ALL with S1905 to a couple of CML trials here, and then also some ALL trials in addition to an AML trial with COG. Up and coming, of course, we're getting geared up for MyeloMatch, and we're hoping to be ready and have validated assays by June. And then there's also the FNIH MRD trials that Jerry's working on, in addition to a pending CML trial that's coming up. And then Anjali and I have this one that we'll continue to talk about. And one thing I do want to highlight is that we do quite a lot of global oncology testing. And you see Jerry on the bottom here with a dry blood spot card. For any biobankers that are on, what we're able to do with these dry blood spot cards, these are completely desiccated. You don't need to store them or anything like that. But we actually have been able to do dry blood spot testing on patients from across the world. And we're able to get these on a validated, clinically validated assay down to MR4 at this point. The 0.01. In addition, we are also serving on the Uganda Cancer Institute molecular tumor boards. Using these dry blood spot cards, we're actually able to do RNA and DNA sequencing off of these cards. So a little bit, Terry's already covered the general schema for MyeloMatch. So first, the de novo diagnoses are mutation driven and will be binned by Matchbox into one of the arms. And from there, for MRD assessment, there's a number of things that we'll be doing, and then they will be further binned into the eraser trials. The main sequencing technology that we're doing in MO, which we're bringing online now, is based off of the Genexus instrument. The key with this is that it allows us to do the library preparation, the sequencing, as well as the data analysis all within the same box. And for many of you, you're familiar with Illumina based sequencing. The ion torrents is a little bit faster because it is based off of pH differences as the base pairs are added. It throws off a hydrogen ion, and it's an ultra sensitive pH meter, so it can detect that single or a couple of hydrogen ions that are popping off with just a little peak measure and change in pH in the bottom here. And so this is the AmpliSeq library preparation that allows us to detect both RNA and DNA in the same library preparation. And this is another key innovation of this platform, because before you had to do the RNA sequencing and the DNA sequencing separately. This chemistry actually allows you to do it together in the same thing. This is the list of targets. We have some key hotspots as well as sequencing of full genes. Here are the fusion genes, the RNA, and also the expression based off of the RNA. And we'll have some control to be able to analyze the expression. And based off of this panel that was really built to detect 93.3% of the variants that are frequently seen in greater than 3% of AMLs, at greater than 3% frequency, and then really 72% of variants that are greater than 1% frequency in AML. So it's pretty comprehensive. It's not absolutely perfect, but for a targeted panel of RNA and DNA targets, this is pretty good. And we expect an average of 1.5 to 2 million reads from the DNA component and 300 to 500 RNA reads. But the key down here is how the Genexus is going to run in terms of timeline. This does not include, specimen receiving, extracting the sample, which will take anywhere, depending on if you have an automated extractor, or if you have your staff do it. But, adding on maybe another 2 hours onto this for the initial specimen accessioning and processing and extractions. Then you can go straight into the library prep. It takes about 10 minutes to set the machine up, and then it takes about 11 hours to do the library prep here. The templating is about 3.4 hours, 3 hours and 40 minutes. And then the actual sequencing is 1.5 hours. And then there's some post-run analysis that takes about 22 minutes or so. And then after that, up here is where your technologist can get in and actually start analyzing as soon as it's even sequencing. And so that is the beauty of this, and this is what will allow us to do our turnaround and reporting within 3 days. So thus far,
Quick question: should I be surprised that ABL1 is not the control for expression?
So we actually don't need the ABL1 to be a control to expression control in this case. So for next generation sequencing, as we're looking at controls, it's actually different. And we've looked at other housekeeping genes for expression. And actually what we're validating now is actually not the expression profiles. Those we can use as exploratory data. So I think the expression genes are going to be really important in terms of looking at how that the expression changes, especially things like WT1, how that is actually different in our AMLs. And so it'll be really good research data, but I don't think we're actually using it in MyeloMatch at this point. But thank you for the question. Okay, so in terms of feasibility and harmonizing studies, thus far, and these numbers are actually a couple weeks old, we've done more than 1,200 samples or so at this point. The QC metrics, and we're doing parallel studies with the NCI MOCA lab to make sure we are harmonized. We finished feasibility studying for version 1, found some issues, and now actually the company has developed a version 2, which is better, and we're not finding issues with that. And so the QC metrics, I mean, 98.2% of all of our runs passed, which was pretty phenomenal. You can see over here, the red dots are the Fred Hutch runs and the blue dots are the MOCA runs. We're pretty much on top of each other. And so fairly well harmonized for pretty much everything across the board. This assay currently has a sensitivity of 99%, 100% specificity. Our limit of detection has been quite amazing. And we were expecting a limit of detection for a threshold of 5%. But actually for our testing, we've been able to detect less than 1% for SNV, 3% for indels, and down to 20 read counts for fusions we've been able to call. And our reproducibility has been, you know, pretty phenomenal. Great concordance. And we actually did an independent FLT3 ITD study on the MO archival samples. And this was because we're worried that in NGS, you're usually interrogating smaller pieces of DNA. And so we were worried that we weren't able to pick up the larger peak ITDs. And so we actually went back and figured out that we could really only detect up to 117 base pair ITDs. And then we further went back and looked at, well, how often do these ITDs become bigger than 117 base pair? And at least in our archives, it turns out to be about 8%. 8% of samples are above 117 base pairs. And then there are minor issues with multi-peak ITDs, but it has no issues identifying FLT3 ITD. For measurable residual disease now, I'm going to turn away from myelo match. And I guess we're a little bit tight on time, so I'm going to keep moving here. So for measurable residual disease MRD detection, you know, I don't have to belabor the point, but basically what we want to do is be able to lower our limit of detection with the tools that we have. We want to be able to identify patients that have perhaps, you know, that will relapse eventually, maybe down to here or even here, and differentiate the purple lines from the blue lines, right? And if we can do that and identify the patients who will eventually come back up with these better tools with lower limit of detection, perhaps these can serve as surrogate endpoints, and we can help to guide our test development and more rapidly. So a couple of methods that we currently use for MRD detection include flow cytometry, and Jerry had mentioned Brent moving to see Children's in Los Angeles. So our UW HemePath lab still exists, and they are still doing MRD testing. And the assay that is left is currently working on is the minimal residual disease for B-ALL, and that's used in the Children's Oncology Group study. And the current director for the UW HemePath lab is Xian Chen. And the overall sensitivity for this assay is conservatively estimated at 0.01%, but really that depends on the blast immunophenotype. If the immunophenotype is different enough from hematogones and they can differentiate, then it allows them to be able to detect that better. And also it depends on how many cells you give them to test. So you have to give them enough cells so that they can go to enough depth for that measurable residual disease. Another way to detect measurable residual disease is RT-PCR, and we use, for instance, an nested assay PCR for detection of BCR-ABL. And this is extremely rapid. We can do this and report this out in 0.4 day was our average before COVID. Right now, it's a little bit longer based off of the last couple of years, but you know, prior to that, it was 0.4 days, and also it reports an international standard. And the P210 assay is FDA approved with the limit of detection down to MR 4.7, and that means 0.0030 reportable range. So for the P190, this is a research use only. We have validated this assay down to MR 4.08, and the reportable range here is 0.01. And this is just an example of what the data comes out and looks like. Now, I wanted to touch on digital PCR because this allows an absolute quantitation. This is different from RT-PCR, which is a semi-quantitative value. And I wanted to compare two platforms that we actually have in our laboratory, the BioRed versus the QIAcuity. The BioRed is a droplet-based digital PCR system. And this allows you to look at about, 20,000 droplets. This is the theoretical limit for oil immersion before it kind of falls and merges in together. And this does have an FDA-approved assay that gets you down to MR 4.7, for instance. And it also has a number of RUO assays that's already developed and available for P190, IDH1, 2, and T315I, for instance. The QIAcuity, this is interesting. This is a fairly new platform. We had it now for about a year and a half. But what this allows us to do is multiplex up to 5 different colors or targets into the same assay. So we've developed an AML panel on the QIAcuity based off of these 5 different colors. And this also allows us to hyperwell. What this means is for this plate that, each of these squares or sample that you put in, there's about 26,000, depending on which plate you use. The maximum is about 26,000 little partitions. And based on these little partitions, what you can do is you can combine a bunch of these guys and use it in the same reaction. That's called hyperwelling. So when you do that, you can actually lower your denominator and get more sensitivity and lower your limit of detection. And so just experiment to see how low we can go, right? Combining just 2 wells gets you 52,000 partition, and we can get down to 0.5 picograms of mutant DNA. That's from mutant cell lines diluted into wild type cell lines. And so, and this is a heterozygous mutation. So it's half of that actually has the mutant allele. So this last 4, we were playing around in the lab with the dilution series, but these last 4 is equivalent DNA that's put in here is less than 1 cell, and we were able to detect it. And that's probably why it's kind of wobbly here and not pretty, but it's less than 1 cell, and we were still able to detect it. So duplex sequencing is the next MRD method. This is the next generation sequencing, allows you to do multiple targets. And this basically is next generation sequencing that tags the DNA, the double-stranded DNA from the very beginning here. And what this shows you is the average error rate comparing different modalities. When you use standard next generation sequencing, you expect an error rate of about 1 in 1,000. But when you then move to the next phase of error correction with barcoding, then you perhaps can get your error rates down to 1 in 25,000. However, if you barcode both strands of the DNA in addition to being able to add this type of error correction on it, you're getting down to 1 over 10 million in terms of your error correction and your precision. And so this is the duplex sequencing tags that you add on both end, alpha, beta here. And from that, you can piece it all back together and use that for error correction. So not to belabor more on the technology, but going into implementation, this is a study that Megan and Jerry did on the SWOG 0106 data. And to go back and look at this study, which was cytarabine and daunorubicin with and without gemtuzumab in de novo AMLs. And they went back and looked at, MRD by flow or MRD by duplex sequencing, which can give us a better separation. And you can see that there is a greater hazard ratios separation with duplex sequencing in comparison to even flow cytometry, which we all know is quite good at this point. But duplex can give us a better separation here. And this, I think, was presented at ASH. So I'm going to move on to the next thing now. For tumor mutation burden, as many of you know, this is used for predicting response to checkpoint inhibitors. It has been useful in a subset of solid tumors, and there's an emerging role of checkpoint inhibitors in AML. And the way TMB is calculated is different with different molecular assay. That has been something that the molecular world has been addressing. You know, Friends of Cancer and a number of organizations have really looked at how to calculate TMB and what is the best way to do this. And we know now that by targeted panel, you oftentimes overestimate the true TMB status if you're not using like a whole exome sequencing method. Well, NovoSeqs were released in 2017, and this enabled about 20 billion reads in a single flow cell, which is 4 whole genomes in a single cell. And now it is possible to really get whole genome sequencing done. But, you know, are we at a point where we want to go there? Well, I'm showing a new technology that is a whole genome sequencing, but it also overlays long range sequencing on top of that, and this will allow a more accurate assessment of the total genome aberration. And so what I'm talking about is going to be proximal ligation or high C sequencing. So what you do with this technology here is you take the cells, you have formalin cross-link the DNA, and this is a natural reaction. Whenever DNA are really close to each other, the formalin causes bridges across the DNA, and these are the cross-link that happens. And so basically what this method does is will then fragment these pieces of DNA, and then using proximity ligation, you basically stick the two ends back together, and you basically sequence these quote unquote fusion areas or these junctions together, and then you know which parts of the DNA were touching each other or very close to each other. And by stitching this up in analysis, the software, by our software later, you can tell where your unbalanced translocations, other translocations, inversions. Chromotripsis is when you have a massive catastrophic event to your genome and you have multiple permutations and aberrations. Any other loss of heterozygosity, other structural abnormalities to your chromosome. So a 3D picture on top. And so this is the workflow. You can start with FFPE or FRESH, and you still do your Illumina sequencing. But then there are multiple ways of analyzing this data because you actually can get down to a pretty sensitive level. To visualize this, this is usually what an Oncoterra heat map look like. I say usually because you will not have all these little dots here. I'll show you in the next one what a comparison between normal versus cancer. In this one, I just want to have you appreciate how the red on the diagonal, this is normal because you have chromosome 1 here and chromosome 1. This is chromosome 2 here and chromosome 2. So when you have chromosome to chromosome, you expect the two chromosomes to be close to each other and to be touching, right? And so this is perfectly normal. However, all these other spots where these black arrows are, you're not expecting this to be a hot spot. You don't expect to have chromosome to chromosome interactions in these other areas. And so when you zoom in, you can actually detect some translocations, whether they are balanced or unbalanced. You can detect inversions, duplications, and deletions. This is the difference between what a normal genome versus a cancer genome would look like. And when you layer on machine learning, you can actually do this relatively quickly. So normal, you expect, you know, the chromosome 2 to chromosome 2, yeah, they're supposed to be touching. But chromosome 2 should not be touching many of the other chromosomes, except in a cancer genome, that's different. You have chromosome 2 abnormally touching 4, so what's happening here? And then also over here, what's chromosome 2 doing with chromosome 9? So these are structural abnormalities that you're beginning to notice by this. What can we do even further with this? This is a really interesting case of a BCR-ABL leukemia, where the leukemic blasts were flow isolated and compared to a remission sample. The remission sample, as you can see, is not there, but this wasn't a simple 922 translocation. On deeper look and higher resolution, you can see this was actually a complex rearrangement of a Philadelphia chromosome, the 922 translocation, but there was also an additional inversion. What does this mean for the fusion, and what does this mean for the pathobiology of this tumor? This will be interesting to study when we can get to this level of resolution, data resolution. And so coming back to the tumor mutation burden is, you know, what if we can actually look at the total chromosome aberration score. In addition to just looking at TMB, we can actually look at how chaotic your chromosomes are in terms of total abnormalities. And, here is one where, fairly low, and considering this to be moderate risk, whereas you have one here where there's hotspots all over the place. And so whether these could be considered higher risk. And finally, if you layer on additional hybrid capture, you can actually get into the single nucleotide variants and actually be able to use the data to call mutations as well as variant detection. If you layer on an additional hybrid capture mode to it. And then kind of for the exploratory endpoints and the more researched endpoints, the other thing that information we're finding out with this type of high-C sequencing or 3D genomic structure is we get to know which parts of the chromosomes are hypercondensed and which parts of the chromosome are open or more transcriptionally available. And what they call this is compartment A versus compartment B analysis. And so you actually are able to then get some epigenetic information and actually see which parts of the chromosome in your genome is more transcriptionally available. Now, for this last section, I want to talk about, future, faster, better, cheaper. Can we have it all? Jerry has always taught me you can have two, you can't have three. But I'm trying to push the envelope here. So I show a picture here of the COVID home antigen test. So these are like, it's very similar to your pregnancy test, but this is a pregnancy test for COVID. And so you see, this is what we've been playing around in the lab with, is developing these point of cares. Can we push it so that we can detect perhaps someday in your oncologist's office, a translocation and a fusion gene, and to be able to help you confirm a leukemic diagnosis right there in the office. And this is BCR-ABL. This is at body temperature. We haven't been able to push it down below 30 degrees, but after 20 minutes without anything special, any kind of special electricity or equipment or anything, you can just do this right on the bench top and pop it in. And you can see here, this is the negative cell line and this is our positive cell line. We are able to detect this in essentially a pregnancy strip for leukemia. And so I am a little Trekkie fan here, but I thought this was interesting. Someday, hopefully, we can get there with our point of cares. And so this is kind of pivoting away from that. For the point of cares, the single molecule long read sequencing is one that this is, all seriousness in here together. Many of you know about nanopore sequencing, and at this point, the error rates in nanopore sequencing have really come down. We're down to about 98, 99% accuracy on these with correction algorithms. And the addition of some rapid library preparations, I wanted to show you some work that could be really exciting coming up. And so by combining the CRISPR enrichment, we're able to enrich for fusion genes of interest. And in the library preparation, we don't actually have to amplify anything. And we basically do a simple cleanup, loading it into these nanopore flow cells. And this is what a nanopore does in sequencing. But really the key here is being able to analyze this online and to implement this in a much more rapid modality. And so here's the key with our initial work here, is that with this online analysis, we're able to really speed up this next generation sequencing long range reads. And we are able to confirm fusions in under 80 minutes and patient samples here in under 3 hours for fusions with this setup. And furthermore, we're actually able to identify specific breakpoints. And this is an example of CML patients that we were then able to develop personalized monitoring assays for when we know the specific breakpoint. And here we want to talk about the S1905 and what we've done in developing here and going beyond molecular. And so one of the challenges with AKR1C3 is that AKR1C3 was novel. There was no standing assay. This is a novel biomarker. There was no clinically available assay to detect and monitor AKR1C3 for this trial. And so there was a level of preclinical development that had to happen. And during the preclinical development for AKR1C3, we tried a couple of modalities. We looked at the protein by Protein West. So we tried a Western assay, and that wasn't very good. We tried this by RT-PCR, and what we discovered during that was that actually the bone marrow erythroid precursors express AKR1C3 at quite a high level, and so we couldn't do RT-PCR on the bone marrow with precision. On the peripheral blood, it was doable, and it actually had a pretty good separation between TALL and normal samples. But as you can see here, there's still some expression in normal samples, although there is a threshold we could set. And this is an example of a normal case where the erythroid expression showed very high AKR1C3 expression in erythroid precursors. And ultimately, we decided that we wanted to do an immunohistochemistry stain on this study, because by immunohistochemistry, we can actually determine what are the erythroids versus what are the leukemic blasts, the TALL blasts. And so with that, we were able to help Anjali and Nick on this trial to get a good biomarker assay for their trial. And further development on this, and this is an example now of our singleplex immunohistochemistry, where we have the normal marrow here versus the case with 70% TALL blasts and having a very high AKR1C3 expression. But we've now also are working on a dual AKR1C3 TDT immunofluorescence multiplex immunohistochemistry assay. And this allows us to get an even higher level of sensitivity and limit of detection. And so this is, the classic case of a group of ALL blasts that have AKR1C3 expression, and you can see the erythroids in the background here. Yeah, okay, fine. They're there, but they're not TDT positive, so you don't call them. And we're able to do that with a multiplex immunohistochemistry. With these very rare cases, you can detect down to a single cell in the pool. And you can see, okay, you have a blast here in this tiny little yellow dot, but it's not AKR1C3 positive. And so you can actually get exquisite sensitivity. And so this is a little bit more work on the codex and also the multiplex immunohistochemistry. I am going to go to my conclusion slide because I know we're running short on time. So we have a lot of trials going on and upcoming. Next day RNA fusion and DNA sequencing is possible, and we are wondering if we can do better, and even same day confirmation and diagnosis confirmation for you. MRD, it depends on what assay you want to use and how low you want to go, but there are other platforms that are available. Digital pathology tools beyond molecular can also help support some of these trials. And so I do want to thank Jerry for all of his mentorship and also giving me a spot in his lab, and the S1905 team for the experience in this trial. This was really quite a phenomenal study, and also all the people that helped me out in my lab and the clinical trials pathology lab and the other labs here. So molecular oncology in the beginning, as you see, has done a lot of this work and is integral to this group. All right, I'm going to stop there. Any questions?
Cecilia, thank you so much. That was a wonderful presentation and just beautiful work. No words to say. It's just beautiful. So thank you for all your work with everything.
Yeah, it was great. It's fun. Jerry Garcia famously said, "In this life, I choose fun," and that's, I think, the words to live by in our work.
And Jerry, you clearly chose well, choosing Cecilia for your lab. Yeah.
Yes. I told people in the lab that I have one good idea a year. And so, don't blow it. So that was my one good idea a few years back. Grab you, Cecilia.
Wonderful. So I think next we're going to go on to Kristen is going to present our ALL studies.
So I will be, since we are running a little short on time, I can run through many of these very fast and then just spend some time on one study, the study of ELISE that is going to be activated soon for older patients with ALL, and also have Katie talk about what's some amendments and some changes in E9181. But first, so I'll share my screen. I wanted to, yesterday, I had one more slide that I wanted to show after talking about TALL really quickly, and just I wanted to express how Steve Coutre was so helpful. I didn't know him well, and I didn't know him for very long, but during the ALL working group meetings, he was incredibly helpful to all of us. And I was thinking, because he wrote also S1401, which was the last ALL trial that was designed in SWOG using nelarabine with a chemotherapy background, that I was thinking maybe we could either in ALL or CLL maybe name a trial for him. And Jerry, I think you are really good at doing this. Anyway, that was—
Challenge accepted.
I just, yeah, okay, and maybe Deb Stevens with her trial, since he was also so involved with CLL and also both personally and professionally. So that was just a thought that I had. I meant to show that yesterday and we ran out of time. So now for the other slides. Okay. Can everybody see these slides?
Yep.
Okay. So I'm presenting on behalf of the ALL working group, which is chaired by Wendy Stock. This is a true intergroup effort. Members of every cooperative group, the Alliance, COG, ECOG, Akron, and SWOG participated in the trial development. We started having meetings in January of 2020, right before COVID, and there are senior and junior investigators that meet about every 2 weeks. They vetted the trial concepts that I'll present, and also present original research that has informed the trial design, and as well as the correlative science objectives. So there's been 2 approved clinical trial concepts evolved from the working group. EA 042001. This is the trial that Ellie designed. It's a randomized phase 2 comparing inotuzumab plus mini hyper-CVD versus dose-adjusted hyper-CVD in older adults with pH-negative B-cell ALL. And also there's a single-arm phase 2 trial that ECOG is leading, EA 9213, that is using daratumumab for MRD in CR, but for patients with T-cell ALL. Then there's 3 concepts in development: the T-cell trial that I talked about yesterday. There is also a relapsed BALL trial feasibility study of inotuzumab and venetoclax, followed by blinatumomab that Jameson is writing, and an amendment to an ongoing trial, A041703, led by Matt Wiedewalt, which will be frontline treatment for pH-positive ALL patients greater than 70 years who are unfit for chemo. So again, the active trials for ALL include EA 9181 that Katie will discuss, because there are some important amendments. Also, A041501 is the phase 3 trial that essentially is the 10403 backbone, but adding rituximab and then randomizing to inotuzumab plus or minus inotuzumab for young adult patients with ALL. Dr. D'Angelo at the Farber is the PI of that study, and Anjali, of course, is very involved in that study, is the SWOG champion or the co-chair. And then in the relapse refractory space, A041703 is the trial designed by Matt Wiedewalt. Again, there are 2 cohorts. There was a cohort for older adults that was inotuzumab followed by blinatumomab, so a completely chemotherapy-free regimen for older adults that were transplant ineligible. That arm has closed. They've met accrual, and the primary endpoint was EFS at 1 year. So that actually will be coming up in June of 2022. So we'll have data on that trial, perhaps maybe at ASH. But there's a second cohort on that trial, and that's for relapsed refractory patients. And it is inotuzumab followed by blinatumomab, and patients can go on to transplant, of course, in that arm. That has about 45 patients, a planned accrual of 45 patients, and that accrual has slowed. So if anyone has patients and they're perhaps INO or blinatumomab untreated, that could be something that you could think about. And then we talked about S1905, which is Anjali's study for relapsed T-ALL. And then there is, just as a reminder, there is a SWOG trial, AALL 1821, that is led by Tracy Cooper at Johns Hopkins, and that is using blinatumomab and nivolumab versus blinatumomab alone for patients with first relapse of B-cell ALL. And Anjali and I are the study co-champions. That is a very large trial with like more than 400 expected enrollments, and they're at about 40 to 50. So that trial has a long way to go as well. So, and I think the upper age limit is 26. The newer concepts, again, the frontline older trial of A042001, that's going to be, it's very, very close to being activated. And then the MRD trial also that's very close to being activated. So Katie wanted to present the updates on the pH positive ALL E9181. So I will stop sharing and she can share.
Thank you, Kristen. Let me just share my screen here. Can you see that okay?
Not yet.
Not yet. Okay. How about now?
Yep.
Is it? Are you seeing the full screen?
Yep. Looks
Okay,
good.
terrific. Okay, great. So thank you so much, Kristen. I'm just going to briefly run through, I know we're at a time crunch here. So this is the EA9181 pH positive ALL intergroup trial. The study, it's an intergroup collaboration led by Yishai Ofran. The Alliance co-chair is Dr. Katrina Jameson. And the study was initially designed to challenge the traditional paradigm of treatment in pH positive ALL. Given the established role of MRD monitoring and tailoring the intensity of therapy in pediatric ALL trials, along with the effectiveness of TKIs and blinatumomab, the trial was really designed initially to study the possibility and efficacy of a chemotherapy-free regimen. In this trial, patients receive, first there's a start of a single arm run-in with up to 3 weeks of TKI and steroids. The TKI can be either dasatinib, pernatinib per investigator choice. Patients are randomized to induction with either a chemotherapy-based regimen or a blinatumomab-based regimen.
This room looks so much better than real.
What's that? The chemotherapy backbone is hyper-CVAD or modified hyper-CVAD if patients are over the age of 70 or unfit. MRD testing is done subsequently, and if they're MRD positive, then they cross over to the alternate induction therapy regimen. So if they receive chemotherapy up front, they're reinduced with blinatumomab and vice versa. If they're MRD negative, then they go on to either allotransplant followed by TKI maintenance, or consolidation therapy followed by TKI maintenance, depending upon investigator discretion and patient preference. The primary objective of this study is to compare overall survival following induction with either a blinatumomab-based regimen or a chemotherapy-based regimen. The secondary objectives are to compare the rate of MRD negativity at the end of first induction, to evaluate the rate of MRD negativity after reinduction for those patients who remain positive after the first induction, to compare event-free survival, assess the toxicities of both regimens, and to describe the outcome of patients who proceed versus those who don't proceed on to allotransplant after treatment with blinatumomab and TKI alone. To be eligible, patients have to be between ages 18 and 75, newly diagnosed with pH positive ALL. The presence of BCR-ABL translocation must be confirmed centrally. They must not have had prior chemotherapy for ALL. It is allowed to have up to 5 days of hydroxyurea for cytoreduction. Also, patients can start on imatinib prior to study registration and are allowed to proceed if they've received less than 14 days of imatinib. Patients must not have prior known organ dysfunction. If they do have acute organ dysfunction attributed to leukemia, they can be registered and start on Arm A, the steroid and TKI therapy, but will only be allowed to proceed to step 2 randomization if that acute injury has resolved. This is a phase 3 design with overall survival as the primary endpoint. For 330 patients, with 330 patients, the study will have an 80% power to detect a 45% reduction in hazard rate in the blinatumomab arm and an improvement in 2-year overall survival rate from 73 to 84%. The accrual rate was estimated at roughly 60 patients a year, taking approximately over 5 years to complete accrual. With regard to the First Amendment that's underway, it's primarily has been some administrative changes, clarifications of eligibility criteria, and modifications to the treatment schedule. And the most recent numbers provided by the PI are that 74 patients have been screened and 68 have been recruited to the study. Thank you.
So just for clarification, if people read the protocol talks a lot about MRD negativity, but that's not precisely true. What the cutoff is to calling someone positive or negative in the study is 0.1 BCR-ABL, which is a little bit higher than most of us would like. But the reason that that's the cutoff is that's what the FDA label says for blinatumomab. So that's what they had to use. So if you get a value back that's, not negative, it can still be considered for the clinical trial as negative.
Thank you.
But we'll be reporting everything, right?
Yeah, the number comes back a number, not a negative or positive.
Yeah.
That's great, Katie. Thank you.
Thank you.
Does anyone else have questions about this? And if everyone's okay, I just was talking with Harry. We can actually if everyone's okay with it, end at 1:30 instead of 1:15 to give Kristen a little extra time because I know we got a little bit behind.
Okay. Can you see my screen again?
Yep.
Okay. And Jerry is amazing. So he already came up and direct messaged me. He already came up with a title, CLL. So for the C in Coutre, out, and then outcomes research. So Coutre, he already did one pass at that in that little time. So that's amazing. So Deb, you can use that. So this again this was the frontline trial that's open to accrual for young adult patients with ALL. It's a randomized phase 3 design. Dan D'Angelo and Anjali are leading. The primary endpoint is 3-year EFS. The accrual goal is 341, and based on the most up-to-date SWOG or SWOG numbers, the accruals are 243 nationally, and SWOG is only 38. I think that's probably low, but just due to that, how SWOG or how other centers can get provided. But I think that's probably low for out of all those patients in our centers because we have pretty high accruing ALL. I don't know. So the 041703, just to remind you, is a phase 2 study of inotuzumab followed by blinatumomab. The untreated older transplant eligible patients, that cohort is closed, and the relapse refractory arm remains open. Matt is also planning an amendment for a cohort 3 for older patients, and that would be untreated adults with Ph positive ALL, and the planned feasibility would be quite small, 15 patients, and I'll go through that. So this is, again, the older transplant ineligible cohort. The 1-year EFS goal is to be greater than 30%. So again, we should be hearing about that trial perhaps, or the first report, maybe at ASH even this year. In the cohort 2, which remains open, is 2 cycles of inotuzumab followed by up to 5 cycles of blin. And you can come off and go to allo at any time. Again, the primary endpoint for the relapse refractory cohort is also 1-year EFS with a goal of greater than 30% EFS. Again, okay, so we can cut through this. So the planned potential amendment to this trial would be using ponatinib and dexamethasone for induction, followed by inotuzumab and ponatinib for 2 cycles, followed by ponatinib and blinatumomab consolidation. So again, this is an amendment, it's in the works, but this trial will probably, if this amendment is approved, this trial will be open for a longer period of time. 1821 is the SWOG trial that Tracy Cooper is leading. And again, it's for relapse patients 18 years and up. They will receive 2 cycles of blina versus blina and nivolumab. And then they can go off trial and go on to allo transplant. The new concepts. So I wanted to spend a little bit of time talking about A042001 that was designed by Elias and now but is being led by Marlies Luskin at the Dana-Farber. So this is a randomized phase 2 comparing inotuzumab plus mini hyper-CVD to dose-adjusted hyper-CVAD without inotuzumab in older patients. The real goal of this trial is to define a new standard of care for older patients with ALL. So patients will be randomized to either inotuzumab and mini hyper-CVD or dose-adjusted hyper-CVAD followed by pump maintenance. We're defining older patients in this trial as 50 years and up because the young adult trial goes up to age 40, and we didn't want to have a gap between obviously 40 and 50-year-olds, and this therapy, hyper-CVAD is intense enough, and the inotuzumab would be probably good for anyone over 50. So the comparison of the treatment arms. So patients will receive course 1 and course 2, or course A and course B, however you think about the hyper-CVAD regimen. Patients greater than 70 years will only receive 2 cycles of induction and then go on to pump maintenance, whereas patients 50 to 69 years can receive up to 8 cycles of induction, and early discontinuation is permitted to proceed on to transplant or due to toxicity. The inotuzumab mini hyper-CVD regimen and the doses is detailed here, and it's detailed well in the protocol. Rituximab will also be included in these arms, and the dose-adjusted hyper-CVAD is also it's dose-adjusted for age, and it's detailed here, and it will be in the protocol. But just for questions about what dose-adjusted hyper-CVAD means for everybody, there it will be very clearly detailed in the protocol, and Elias is on the call, so we can ask him if you guys have specific questions about the regimens. The primary objective is to compare the event-free survival of the novel arm to the standard arm at the end of cycle 2, and EFS is defined in this trial as time from registration to an event. And then an event is described or defined as failure to achieve MRD negative CR or partial CR by central flow-based MRD analysis after 2 induction cycles. And then relapse from MRD negative CR at any time and death from any cause. So the response assessments will be done at baseline. At the end of cycle 1, both flow-based and clonoSEQ-based MRD, and also blood clonoSEQ will be done as a correlative. And at the end of cycle 2, which is the primary endpoint, all the those assays will be performed, and then also at the end of the intensive phase, i.e. before pump maintenance or transplant, or if a patient comes off for alternative therapy. Any questions about this trial? This trial is very close to being activated, so we expect it in hopefully by summer. So the next trial is EA9213. This is a daratumumab trial for MRD for patients with T-cell ALL. Again, the key eligibility patients must be in a hematologic CR or CRI, but have persistent or recurrent MRD, and that can be even after transplant. The primary endpoint on this trial, which is planned for a 20 patient trial, is becoming MRD negative, or the MRD negative rate after 4 weekly doses of daratumumab. So this is the trial that is planned. It's a feasibility trial of inotuzumab and venetoclax, followed by blinatumomab for the patients with relapsed refractory B-cell ALL. And again, this is just a proposed feasibility trial right now. The trial is still being developed, but the idea would be a dexamethasone venetoclax lead-in, followed by inotuzumab and venetoclax for 2 cycles, followed by 4 cycles of blinatumomab. The hope is that this relapse platform can start to incorporate some novel agents, and that we can ultimately develop randomized studies to determine what the best sequencing of the antibody therapy is, and also safety analysis for addition of novel agents to the antibody therapies. So, for example, something like this, we could envision, based on some of the data that will be generated in, Matt Wiedewald's trials that are ongoing now, and then that feasibility trial with adding venetoclax, and developing or having that control arm or the standard of care arm determined in Elias's trial would be the basis for a future frontline phase 3 trial in the relapse setting. So something like this, inotuzumab plus mini hyper CVD versus venetoclax and mini hyper CVD versus inotuzumab and blinatumomab consolidation versus inotuzumab venetoclax divided, followed by consolidation blinatumomab. For older, then again, this would be for older adults trying to understand, the best regimens for them. And that's really all I had. That's pretty much ALL quickly.
Thank you, Kristen. That was a great overview of a lot of studies. You did a great job with that. Does anyone have any questions?
Okay.
All right. Well, thank you very much to everyone for attending, and to all the speakers for great presentations. It's really a wonderful meeting. Thank you.
Yeah, thank you all. Drive safely home.
Well,
take care.
Thank you,
everyone. Thanks, everyone. Bye-bye.
Thank you. Bye, everyone.
Thanks, everyone. Bye.
everyone stay safe and sane.
Yes.
Bye-bye. Take
Bye.
care. Bye-bye. Bye-bye.